So the idea, basically my name is Taofik Ahmed Suleiman. So as she rightfully said, I'm a joint PhD student in biomedical Georgia Institute of Technology and Emory University. So today I'll talk about from pixel to prognosis, building interpretable AI biomarker for personalized clinical risk prediction. So the idea behind this is to show us current research going on in the area of opportunistic imaging and its incidental finding, specifically giving us the concept or the notion that CT scan is a scan that image the entire body and not just the tumor. And leveraging this in an opportunistic fashion can give us imaging derived biomarker, which is personalized to individual patients. As we continue, we understand that better. So why does this actually matters? So for clinical translation, interpretability is not an option. So let's take, for example, we are all used to, our Zoom, we are all used to the word deep learning. We train a model, we give an image to the AI, the AI give us some fancy looking result. But the major problem we have with this result is that for a computer scientist, this generally makes sense. For an engineer, it makes sense. But for a clinician or a doctor who is actually which these tools is going to be helpful, who are actually going to use these tools, it doesn't really make sense to them because it's all about black box. So that's why interpretability is very, very important, especially for clinicians. They have to know how this model is making the prediction because human life is involved, right? So interpretability is not an option. So basically, the easiest way to introduce interpretability to model is through radiomics. So basically, what we do in radiomic is we try to handcraft the feature we are extracting from the image, and then we train a conventional machine learning model to learn from this feature. So when I say handcrafted feature, what I mean is that I have an image. Instead of just feeding it to the deep learning, I look at the image and I ask myself, what are the features that I should extract from this image myself? And I was like, okay, I can see the volume of this tumor, and I know clinicians are very interested in the volume of a tumor. As the higher the size of the tumor, the likelihood of the aggression or the more aggressive the tumor will most likely be. So I was like, okay, volume should be an interesting feature to use. So I decided to manually extract the volume feature. Then I see the texture of the tumor. Maybe the tumor is looking very coarse, the tumor is looking very rough, the tumor is looking really smooth. And I was like, okay, why not extract a feature that shows this, that represent this texture? So from here, I was able to derive different type of feature by myself. So these features that I derive is what we call the radiomic features. So why is this feature important? When you go in and train your model and you are discussing with a clinician about your model, you can easily tell the clinician, look, this model, what is trained off is mainly the volume of the tumor, the texture of the tumor, whether the tumor is coarse, is rough, is smooth. That way, the can easily relate to it, and then you can show some feature map of these features, which we are going to see as we move forward. So that's the introduction to radiomics. Then also beyond the tumor, I would like to say this. My research is very, very focused on cancer, specifically lung cancer. So I might be biased towards cancer, but just take it as this presentation can literally be applied to any form of disease. It's not restricted to cancer, even though this presentation is very, very much focused on lung cancer specifically. So now beyond this tumor, you can generally see two patient diagnosis of lung cancer, maybe non-small cell lung cancer, for example. These two patients, the same type of cancer, you give them the same type of treatment, but at the end of the day, one of them responds to the treatment, the other did not respond to the treatment. So the question now is, why is one person responding to treatment and another person is not responding to treatment, whereas they are receiving the same type of treatment? Now, this is where we move beyond the tumor itself. So can radiomic be used to actually answer this question? Yes, there are several studies that are currently ongoing where we use radiomic instead of viewing the tumor itself. We use it to opportunistically look at the whole body. Because when you have, like, when you go for a CT, let's say you go for a chest CT, the chest CT is going to capture the lung, the airway, and several organs around it, right? So why not? What if we can look at these organs? We are going to get, like, in form of an overall status of this of individual person's health, and that lead us to what we call personalized medicine. So what this simply means is that the tumor centric approach, while they are helpful, it also completely ignores the overall health of the patient. So through the course of this presentation, we are going to see several case studies where we can actually model the health of the patient itself. So what are the clinical needs? So the idea here is for us to be able to have a personalized risk stratification model beyond the tumor itself. That is, as a doctor, when a patient comes to you, you could easily decide before you give a treatment to the patient, you could easily decide, okay, this patient immunotherapy is going to work for you, or this patient chemotherapy is going to work for you. Why this is important is that for cancer, for example, when a patient is diagnosed of cancer, then time is of the essence. Once the cancer, then that's the killer of cancer. It becomes really difficult to treat. But if you know the right treatment at the right time and you give it at the right time, then the war against cancer can easily be won. So what if we can have this personalized risk where individual, we can easily say, okay, for you, we are going to go for immunotherapy. For you, we go for chemotherapy. So this is a typical case study example. So I titled this imaging the individual because we are generally moving beyond the tumor itself. So let's say we have this CT scan. If you look at this CT scan, this is the lung, this is the lung. So, and all these are the vessels. So now, if you look at, you could see there's a big lump here that is missing here. So now, which is where this arrow is pointing to, right? So this big lump is a lesion. So we don't know if it's cancerous or not for sure. So you could basically train an AI model to detect if this is cancerous or not. That's an easy problem. So now, but the idea is what we currently do when we train radiomics, which I'm going to still illustrate, is that we look at this image, we try to have a bounding box around this tumor region, and we extract features from the tumor region, potentially ignoring the entire patient lung, the airway, and other nearby organ. But if you look at this patient, for example, you realize that this person has a larger lungs compared to this. If you look at this CT scan, this top part, I don't know if you guys see my mouse. So this top part is what we call the subcutaneous fat. So it's basically the fat. If you also look at this CT scan, this upper part is also the subcutaneous fat. That's the fat of the skin itself. So what do you notice between these two CT scans? You realize that the first one is more fatty compared to the second one. So what this is telling you is that potentially, if you are to see these two individuals, this person will likely have a higher weight than this person. So beyond looking at the fat itself, you can also look at the skeletal muscle. So just after the fat, we have this skeletal muscle right here. It's difficult to see, especially if you're not used to a CT scan. So now, if you look at the skeletal muscle of this guy, is more pronounced compared to this guy. What if we can, instead of focusing on just this tumor, what if we can train a radiomic model that can actually look at all these physical characteristics of the individual itself? That way we can have a better biomarker for predicting treatment response or disease outcome, as the case may be. So that's what we mean by imaging the individual. And how do we do this? Firstly, is looking at the organ. For this very image is the lung. But if you take a 3D CT scan, of course, when you scroll it, you are going to potentially see different organs, including the liver, as the case may be. Another way of looking at it is the body composition. Body composition is what I explained just now, which is like the fat, the skeletal muscle, for example, the subcutaneous fat, as the case may be, or biological aging itself. So what if you can actually know the age of the organ? So what I mean is that when you see two individuals, let's say two people of the same age. They are both 60 years old, and you are a clinician, and these two people come to meet you, and you diagnose them of the same disease. However, one of them is very, very much sick, while the other person is still very healthy, still go every weekend to hike and the like, but they are of the same age. So the question now is that why are they biologically different? So this is typically telling you that even though they are of the same age, their organs have aged differently. And this could be as a result of metabolic activity, as the case may be. But what if you can also train a model that can actually predict the actual age of that organ? Let's take, for example, the two individuals that are both 60, maybe one of them, the organ is actually looking like an 80-year-old organ. So what if you can actually have an insight into this organ? So these are all concepts of imaging the individual itself. So what are the potential application of this? Where can we apply all this? So the first place to apply this is personalized treatment, response prediction, and survival analysis. What this means is that you can easily predict the overall survival of a patient that is diagnosed of certain type of disease, maybe lung cancer, for example, or the treatment response. So what this simply means is that on the long run, when a patient is diagnosed of, let's say, cancer, you could tell the chances of a certain treatment working and also the overall survival of the person. So if a person presented to you have low chances of survival, that is a high risk patient, that way you know that you have to be aggressive with the treatment. But if a person presented to you is a low risk patient, then you don't need to be aggressive with the treatment, because we all know cancer treatment, especially chemotherapy or immunotherapy, they are very, very aggressive and they reduce the quality of life. So you want to reduce it where necessary, and you want to be aggressive where necessary. So another way is to predict a disease long term before it occurs. Just imagine you can predict cancer 10 years before it happened. So in our lab, where we look at the eye, and we use the images from the retina to predict advanced neuro disease 10 years even before it happened, to predict cardiovascular disease 10 years before it happened. So these are where all this happen, because most of these diseases don't just surface. The changes started happening in the organ long before the disease itself manifested. So what if this model can actually do this from routinely acquired CT scan? Okay, so it's all okay about the biology and everything. So let's go to the AI parts, right? So the radiomic part. So how does this generally work? So this one big figure is just like a typical example of how you take an image and you make prognosis. So if you look at, this was part of the work I presented in RSNA 2 months ago. So if you look at, or 1 month ago probably, if you look at this image, this is a typical CT scan. So what we are doing is, instead of focusing on the tumor, we decided to say, what if we extract several features from this person? So if you look at this image, we segmented the lung itself, we segmented the airway, we segmented the liver, we segmented the spleen, we segmented the visceral fat, we segmented the subcutaneous fat, and we segmented the skeletal muscle. So now that we have all these different type of segmentation, we go inside the liver, we extract third radiomic feature from the liver, that is the shape of the liver, the intensity of the liver, and the texture of the liver, that is how rough it is, how coarse it is, as the case may be. Then we also go into the lung itself, we extract this same feature. We also go into each of these organs, we extract the feature. Now that we have so many features from different organs, we can now do what we call feature selection, that will allow you to select which of these among these features are the most prognostic feature. So if you look at this, you could see this explainability map, where we try to highlight which features from these organs are contributing most to our decision making. Here, this is a typical example of the lung and the liver. We see that the volume of the lung is very important. The extent of the liver is very important. That is how the liver is extending. Then the standard deviation of the liver, this is basically the intensity feature. Then the mean of the lung and the mean of the liver. These are very, very important. These are intensity feature. And with these features, we're able to classify the patient into two groups. I'll still show a typical example that give a better illustration of this. We're able to classify this patient into two groups. That is the low risk group and the high risk group. So when you see this curve, we call it the KM curve, Kaplan-Meier curve. For those not familiar with this, what this curve simply means is that you are separating, you have a bunch of patients, you separate them into those that are low risk and those that are high risk, and you're trying to see how they perform. These are retrospective data. That is, we already know the outcome of this patient. We already know which of them ended up dying and which of them ended up living. So our model now, we train it on subset of this data and we try to predict it on the unseen data to see if it can differentiate it. So if you look at this curve, what this is telling you that those patients on blue, they are the low risk patient, and you see their survival probability is at the top. So which means they have higher probability of surviving. Then when you look at those patients on this red, you see how they go down really fast. So which means they have low probability of survival. So this is a typical example of how we model it. So now let's see the, how these radiomic features are being extracted. So I'll use a typical example of the lung and the liver. So what we generally do is that we have this CT scan, we bring out the lung from the CT scan. So this is the lung itself. So now from this lung now, we decide which features we need to, we are not giving it to any deep learning model now, we are deciding by ourselves, which features do we need to extract. What make the easiest way to go about this is to use a package we call PyRadiomics. So what this package does is that it extracts all available radiomic, most of the radiomic features that you know. Like for example, for the shape feature, it extracts the volume, it extracts the ferricity, it extracts the elongation, it extracts so many shape features from this organ. Then it also extracts intensity features, that is the mean intensity value, the median intensity value, the percentile, and several first order features. And then finally, it also extracts several texture features for you. It mainly uses grayscale coherent matrix and several other grayscale matrices to extract this texture feature. However, you could decide to go beyond this pyradiomics by defining your own matrix yourself, as the case may be. We have different type of filter. We have the Gabor filter. Gabor filter also extract texture. So if you look at this, what I would like to point out is, if you look at this liver, this is the liver. If you look at the liver and you look at the lung, you see that they both have different texture. What this means is that by the time you compute the texture of the liver, what you are going to have will be different from that of the lung. That's why each of these organs, they are very, very important and they provide different clinical information. So now, to extract radiomic feature, you have to put three things at the back of your mind. You need to extract shape features, you need to extract intensity feature, and you need to extract texture feature. So the shape feature could be any form of features that I've listed before. So this is a typical example of a radiomic feature that have been extracted. Then you use it to train your model to predict treatment response, and then you provide the sharp value to show which features is most important. So what this means is that when you now talk with the clinician, you can tell them that, okay, from my model, what I'm using to train my model is I'm computing the elongation of the lung, which is a metric they also use. Oh, I'm computing the texture of the lung using several tools. I'm computing the first order skewness of the lung. These are things that are very relatable to the clinician. Then beyond this, you can also plot the heat map of this radiomic feature. This is a typical example of a radiomic heat map. So now you train a radiomic model to classify patients into low risk and high risk group. So if you look at this image, we have two CT scans of two different patients. So one of them is a low risk group. When I say low risk group, I mean people that have low risk that they are at low risk, that is, they have their probability of survival is very high, and they will most likely respond to treatment. Then when we say high risk, we are talking about patient that has that has that can easily die, that died pretty much faster, right? That won't respond to treatment. So they are at high risk of death, basically. Why these are at low risk of death. So now, if you look at the radiomic feature, you realize that I will use this last one as a typical example. When you compute the vasculature around the tumor and the vasculature around the tumor for high risk patient, you realize that for the high risk patient, their vasculature is extremely very rough compared to the low risk patient. For the low risk patient, you see their vasculature is there is not much tortuosity going on. But for this, there are way lot of tortuosity. The same way, if you look at this, there are heraldic energy. Each of these are different type of radiomic feature. You see that for the low risk patient, the tumor, the boundary of the tumor is very haphazard, while the boundary of this one is more circular. So these are like very explainable that when you talk to clinician, they could easily relate and trust your model the more. So let's look at case study of how this can be applied in real research. So this is basically a paper that was published sometimes in 2024. So what they do is, this is an incidental finding. So in this paper, they they basically take the CT scan and they segment out as many organs as possible from the CT scan. So as you can see in this image, this is the liver. These are different organs from the CT. So what they do is that now that they have this organ, they extract 15 radiomic feature from each of these organs. They have 32 organs in general. So before now, what we normally do is we just take the radiomic feature and we extract organ from this radiomic feature. But now we are moving to more imaging of the individual, personalized medicine. So what we do now is we segment the patient organs. Then from this organ, as you can see in this study, they extracted 15 radiomic feature from each of these organs. Now, from these features that they extracted, they train a machine learning model out of it. The interesting thing about this finding is, if you look at this figure at the top, they predict 10 years all-cause mortality, and they got an AUC of 73%. Just imagine you have a model that can predict all-cause mortality with 76% accuracy. For you to know how good this model is, when they use normal demographic information, that is including the clinical data, that is the data that they generally have from the patient history, they were only able to, the AUC to predict all-cause mortality was just 65%. But when they use imaging, that is when they use features from each of these organ, the accuracy increased by 7%. And when they combine both the clinical information and the imaging feature itself, it increased by 8%. That's additional 1%, right? So now, basically, what this is telling you is that when you image the individual organ itself, it will provide you an even more robust prediction compared to the tumor itself or any clinical information available. And you can see the explainability here. So in this top image, they are telling you the organs that actually contribute to this prediction. So they are telling you that, okay, to produce all-cause mortality, by the way, this prediction is for lung screening, right? For patient diagnosed of lung cancer. So if you look at this, you see that they are telling you that the CAG is very important. The aorta is contributing really well. The pulmonary artery is contributing well. The liver also has contribution down to the stomach itself. So these are pretty much very much explainable. Then when they do the 2-year all-cause mortality, the model was 71% without any difference with clinical risk. And when they use the clinical data itself, they have less than 60%, which is like a really good result just looking at the CT scan. So another typical case study will be, let's see. Another typical case study will be personalized personalized prediction of immunotherapy response in lung cancer patients using advanced radiomic and deep learning model. So basically, what this study does is it first follow the traditional way by computing the radiomic of the tumor. You see, we have a model that segments the tumor. We have the tumor. From this tumor, we compute our radiomic features, basically from the tumor. Then the study moved further to segment the lung itself. As you can see, this is the lung. Then from this lung, the study segments the vasculature of the lung, that is the lung vessel, that is all these vessels that we see. And this is the vasculature of the lung, and it threshold it to have a binary mask. So from this binary mask, we he overlap it, the study overlap it with the tumor itself and then extract vasculature features. So now we are moving from just tumor feature to vasculature features. And then they also have the clinical feature. So we have three things now. We have data from the tumor itself. We have data from the vasculature of the tumor, which is gotten from the lung. Then we have data from the clinical information, which are the data the doctors generally have access to. Now, let's see the difference between this result. If you look at this 3 km curve, the first one is predicting progression-free survival. So when I say progression-free survival, I mean how long it takes when the patient start treatment, how long it takes for the tumor to continue growing. So if we use the clinical data from the doctor, you see that we couldn't predict the treatment response. So basically, this plot had to predict treatment response. We couldn't predict the treatment response. But however, when we use CT data from the tumor that we compute the radiomic feature, we could predict the treatment response. We can easily, you see there's a clear separation from our model. Those ones in red are patients that did not respond well to the treatment. So these are all immunotherapy patients. While the upper one are patients that did not respond well to the treatment. Just imagine you know this before giving the treatment. If you already know these patients are not going to respond for the treatment, you won't have to give them that treatment. You look for another alternative treatment like chemotherapy, as the case may be. And then those that you already know that are going to respond well to the treatment, you give them. And when they now combine both this third result now is when they now combine both the tumor itself and the vasculature. You see they even have a better separation with p-value of 0.01. Then the final case study I also show, this one is even what I love the most because they didn't have to train any model to do this. It's just simply volume quantification. So this is a study that used body composition. So when I say body composition, I'm talking about the subcutaneous fat, the visceral fat, and the skeletal muscle. So what this study does is that they segmented the CT scan to segment the body composition, the 3 body composition at the L3 slides. So now this study was heavily validated across 4 academic institutions, because validation is very important when you do this study. You have to be sure, because we are directly impacting life. So you have to be sure that your model works really well. And one way to do that is to make sure you validate it across different academic institutions. So if you look at the body composition metrics from the L3 slide, which is right just at the abdomen. So this is the skeletal muscle. If you look at this patient, this green, just before the green, the color at the boundary, I think that's like light brown or something. I have no idea. I'm not a color fan. So this is typically the subcutaneous fat. Then if you look at the green one, is the skeletal fat. And if you look at the brown one, is the visceral fat. So if you look at this first image, you discover that the skeletal muscle is very high for this patient, whereas the subcutaneous fat is very low. But however, if you look at this patient, you discover that for this patient, the skeletal muscle is very low. But what happened? The visceral fat specifically is super large. Then if you look at this particular patient, you see that the subcutaneous fat is very high, but the skeletal fat and the visceral fat, sorry, the skeletal muscle and the visceral fat are low. So these are three different patients representing three different phenotypes. So this why body composition is very important. And in biology, we know that visceral fat is the dead fat. Those are the visceral fat is the unhealthy fat you don't want to have because they are the fat associated to your organs and they are actually the killer fat. Subcutaneous fat are generally healthy, right? So, which means this kind of patient indeed too are at way more high risk than the other patient. So, doing this study alone, just quantifying the volume of subcutaneous fat, the volume of the visceral fat, just the volume, we don't have to train any model. We saw that in this study, this was published in JAMA Oncology in 2024. So they saw that for overall survival, if you look at the clinical data itself, they were not, okay, let's use the p-value. The p-value is easily understood by everyone. If the p-value is less than 0.05, that means it is statistically significant, the result. So if you look at all these results, the first four results are not statistically significant, and they are looking at clinical data that doctors normally look at, like the BMI, the sex, the treatment, and the like. But when they look at the PDL1 expression level, it was statistically significant, which makes a lot of sense because PDL1 expression level are what are the main expression level that the doctors actually look at. But however, when you now look at the body composition itself, let's come here. Look at this. We have less than 0.01 just by looking at the skeletal muscle. So which means, and the risk is 0.04. So which means for patients, the skeletal muscle is very, very important. Just the volume of the skeletal muscle. Then if you also look at the density of the subcutaneous fat, if you look at the density of the visceral fat, they are all significantly predicting outcome of a patient, just the body composition. And this is why most of the time doctors try to advise you on the type of food that you take, the type of food you consume. So this is basically what this body composition are capturing. So what is generally the take home from all this? So the take home from all this is that radiomic features from this multi-organ encode clinically meaningful information about systemic health and survival. So in general, these CT scans are not just for scanning the tumor alone. They are for the whole body, and we can derive a marker from each of these organs of the body just from the CT scan. So, and when we can generally look beyond the tumor characteristic and look at the lung, the liver, the muscle, the fat, and this is only when we can see a complete biological picture of a patient, and that way we can also better predict the risk stratification. So to wrap this up, in conclusion, I'll say CT is not just a tumor scan, it is a window into systemic health and clinical risk. All these studies that I have shown, they are basically called opportunistic imaging and incidental finding. However, another case study I would have loved to show, but because of time I didn't, is the concept of biological aging. You can try to read several research papers in this concept. You see how the biological aging also work. Then in general, I'll say that routine CT imaging contain interpretable imaging biomarker of whole body health. So this generally is like a call for us to move beyond just analyzing the tumor when we try to predict treatment response or outcome, clinical outcome in general, and move towards a more holistic review by phenotyping different organs in the body. And this is only where we can have a personalized and meaningful risk prediction where we can say this individual, yes, this is like your overall health status and you're at high risk or you're at lower risk. And I'll be glad to answer any question from here.
Thank you so